Hello everyone, it's 7:30 now, and we are here with another class of genitourinary malignancy, RT planning on GU malignancies. And today's topic will be focusing on prostate and bladder. So I think we are going to wait for another 5 minutes for other participants to join, and then we are going to start over. So as all our speakers, respective speakers have joined, I think we should start the program. And our expert, Professor Dr. Shantanu Pal, is unable to, unfortunately, is unable to join today due to some personal emergencies. So I will request Dr. Abhishek Basu, Secretary AROI West Bengal chapter, to start the program and call our first speaker. Over to Dr. Abhishek.
Good evening, everyone. I hope I'm audible.
Yes, you're audible.
Yes. So, thank you, Monideepa, for introducing today's lecture. So, this is something in the long line of webinars that we are having on the aspects of conventional as well as conformal planning. Both the lectures that we have today are on conformal planning of genitourinary malignancies, prostate and bladder. And it is my pleasure to call upon the first speaker for this evening, Dr. Jyotiru Goswami. And I believe he will be speaking on the conformal aspects of planning of CA prostate. So I would also ask all the participants to kindly cooperate with the MC, Dr. Monideepa, so that you can post your questions while the talks are going on, and then we would be in a position to ask the questions. And also just to inform that we are going to have uh, another um, webinar. I'm extremely sorry, another CME on prostate cancer. This will be in hybrid mode, both physical as well as we have some eminent national and international faculty who would be joining us online for this. And this would be on the 26th of November. That is a Saturday at Taj Vivanta. And I know more than 100 people have already registered for the event, and we look forward to seeing you all there. So with these words, I would hand it over to Dr. Goswami to continue his talk. Thank you.
So thank you, Abhishek. I hope I'm audible. I will
Yes.
now share my slides. Is it visible?
Yeah, it's visible.
Okay. Right. So we're beginning with conformal radiotherapy planning for prostate cancer.
No, it's not visible in the slide sharing a full screen mode.
Oh, so shall I keep it in the partial mode?
Okay.
Yeah. So conformal radiotherapy planning for prostate cancer. And as I said in my talk in the head and neck section, the reason we do conformal radiation in any site is that we want to reduce the normal tissue complications, and we also would like to try and achieve some degree of dose escalation. Now, the workflow, just in case any of you have joined later on in the series, so I think most of us are used to doing conformal radiotherapy, but broadly speaking, it begins with immobilization and then CT simulation, following which we draw the contours and of the targets and the organs at risk on our planning system. And we then, once we are happy with the plan, we send it to the treatment linear accelerator. For IMRT and VMAT cases, we would also want to do patient-specific quality assurance of the plan before we start. Now, prostate radiological anatomy, I'm not going into that in detail because I think we've already discussed that. So we all know where it is located. But I think it is worth just looking at some preparatory steps before we move on to the planning proper. So we do need some pre-treatment diagnostic investigations. I think we all know most of these, but it is important that an MRI is done and that we also do some sort of assessment of the bones via a bone scan, or today we also have the PSMA PET scan. What we treat depends a lot on the risk of that site being involved. And one of the key areas, or the differences in practice is based on whether we treat lymph nodes or not. So a lot of us have heard of the Roche formula. It's quite, some have said it's almost outdated now, but in fact, it is still something routinely used by the surgeons, and it uses the patient's PSA and Gleason score to derive a risk of positive lymph node involvement. And more, if you like, importantly, we've got the risk stratification of organ-confined prostate cancer. I think this is good to keep in mind. Whenever you see a prostate patient, try and look at the stage, the PSA and the Gleason score, and try and put them in a risk category, because that will help you to make a decision about how to treat them. So we know that low-risk prostate cancers are ones with T1 or T2A disease and PSA less than 10 and Gleason up to 6. All of these have to be satisfied. For the intermediate risk, it's T2B and PSA 10 to 20 and Gleason score 7. Whereas for high risk, T3 or 4, PSA more than 20 or Gleason more than 8. It's important to know the risk stratification because we don't treat all prostate cancers. We can actually do active surveillance for low risk and even for intermediate risk. Radiotherapy is an option for all the risk levels, and surgery, even though the surgeons would have us believe is possible or feasible at all stages, I think is more appropriate for low and intermediate risk. Additionally, the use of androgen deprivation comes in from the intermediate risk category, where we use a short-term ADT, and for high risk, we would use longer term of 2 to 3 years. Now, moving to radiotherapy simulation, we know that the patients mostly are simulated in the supine position. We don't use thermoplastics because the main component of motion is internal motion in this case, and we cannot control that with a thermoplastic mold. So we just use a knee rest and a leg rest. The arms are usually on the chest. I think most of us follow a bladder filling protocol where we ask the patient to void, drink a certain volume of water, and then we treat after a certain degree, a certain duration of time. In the West, they also do bowel preparation. So they would normally use laxatives for patients before simulation and during the first few fractions of treatment. And the advantage of doing that is that we ensure that the rectal diameter is within a certain measurement, which is usually 4 centimeter. The planning scan is usually done with contrast unless the renal function is compromised. We normally use 3 millimeter slices, though 5 millimeter is also fine. We usually scan from the top of L4 to the greater trochanters. Starting off, I think it's important that we all know how to draw the organs at risk. So I think for any of you just starting to do any radiotherapy planning for prostate, it's a good idea to draw the organs at risk first. It's quite easy to do, and there are atlases available. So the structures are the rectum, the urinary bladder, and the bowel. I think that's true for any pelvic structure. Specific to the prostate, I think the penile bulb is very important to draw, and we also draw the femoral heads on each side. Now, coming to the primary contouring, this is for radical treatment of prostate cancer. The CTV is the entire prostate. There is data on using boost doses to index lesions based on biological imaging or even an MRI, but that's not a standard of care. We sometimes will use an MRI scan to better localize the prostate apex, which lies 1 centimeter superior to the penile bulb. And we also can use an MRI to distinguish the prostate capsule from the adjacent levator muscles. So as I said, the entire prostate is always part of the CTV, but for intermediate risk, we would also include the base of the seminal vesicles. And for high risk, we usually will include all of the seminal vesicles. In case of extracapsular extension, we would usually apply an expansion on the prostate, not the seminal vesicle, an expansion of anything between 3 to 5 millimeters. Not everyone does this because if you use a large enough PTV margin, you sometimes end up over-treating. But I think it is worth doing so if you are definitely sure that there is extracapsular extension, which is mostly in the high-risk cases, almost never in the low-risk cases. And then we usually will apply a PTV margin of around 7 millimeters, especially if we have daily imaging. I don't think we need to apply a larger margin than that. We do tend to skimp a bit on the rectal, on the posterior margin, basically to save the rectum as far as we are able to, so that we can use a margin of even 5 millimeters posteriorly. Lymph node contouring, as I said, lymph nodes are mostly treated in high-risk patients. So even then, there isn't an overall survival benefit. There have been some important trials in this regard. There's been an RTOG trial, and there's also been an important trial from Tata Hospital, Mumbai. But there isn't really conclusive proof that treating the lymph nodes is better, but it probably does improve the patient's disease-free survival. So we would treat the lower common iliacs and the external internal iliacs along with the obturator, intra-iliac and presacral nodes. Just as we would in the case of the cervix, it's just the same lymph nodes. And PTV margin is usually 7 millimeters around the CTV. The CTV nodes themselves is generated by using a 7 millimeter margin on the vessels. So it's vessels plus 7 millimeters edited and then added another 7 millimeters for the PTV. Unlike other sites, I don't think any of us routinely will boost gross lymph nodes. because the patient is already on some form of systemic treatment in the form of ADT or even chemotherapy. So, I mean, I would not want to boost gross nodes. And I thought that we could just have a look through the RTOG contouring atlas for primary prostate cancers, radical prostate cancers. Yeah, so let's do that. So we're starting up top, just waiting for the volume to appear, and you see the iliac vessels in orange and the presacral space in the middle in green. We try and have a thickness of about 1 centimeter in the midline to cover the presacral nodes. Remember, you can't see these nodes, so you have to basically treat the space. So going down further, and then you see the division into the internal and external iliacs. Follow those down. And we're basically waiting here till we see the head of the femur, which is when we will stop. You see, just at the head of the femur, we will stop following the external iliac node. That's the one in the top, because these will continue downwards as the femoral nodes, which are not draining lymph nodes in this case, but we will follow the internal iliacs, or the opposite, in fact, down below till is there. So sort of the bottom of the symphysis is where we will stop. There are actually 2 contouring guidelines for radical prostate, and there are 3 for post-op prostates. So I've got those at the end of my presentation in case any of you want to check which ones to read. So moving on to post-operative prostate radiotherapy, it's quite a vexed issue because there isn't really a consensus yet on whether we should treat prostates post-operatively. Again, there is no overall survival benefit of upfront adjuvant radiotherapy versus salvage radiotherapy in case of rising PSA, but some trials have shown that there is better biochemical relapse-free survival. However, remember that patient has already had surgery, so adding on radiotherapy is going to be a bit toxic. The indications are positive margins, capsular breach, and seminal vesicle involvement. The prostate bed is the CTV. We'll look at the boundaries of the CTV in the next few slides. So broadly speaking, we have to cover the anastomosis. We have to go up to the bladder neck. We have to include the apex, and we have to treat laterally up to the neurovascular bundles. Like with radical radiotherapy, we use a margin of 5 to 7 millimeters around the CTV. And unlike the radical prostate, there isn't really any evidence to treat the lymph nodes. However, unlike in the past, we also are now adding androgen deprivation therapy more often in the case of adjuvant radiotherapy. So that's a diagram showing the sites of local recurrence. So you can see that these are the sites we need to cover when we treat post-operatively. The tips and tricks really are that the most inferior slice where the urine is visible, that's where the anastomosis is located, just one slice below this. So you want to cover that. The anterior border lies behind the symphysis pubis, and the anterior border also will encompass some volume of the bladder. So you don't actually go into the bladder, but you go beside the bladder. I'll just try and see if I can get the pointer. I don't think I can get the pointer in this mode. Anyway, so if you can follow the arrow there, so you can see that the boundary of the CTV is invaginated beside the bladder. And this is to cover the neurovascular bundles. And going up above, we have to check where the vas difference is visible, just superior to the seminal vesicles, and all the clips that we can see, we should cover those. We look at two different case scenarios. These are part of the RTOG atlas. So one is where we've got positive margins at the apex. So we are starting up, that's the covering where the seminal vesicles were. You can see the clips. We're going slightly into the bladder there, just to cover the anastomosis, and going laterally all the way to the lateral pelvic wall. But going low, we have to make sure that we are coming onto the hypophysis there. And the other scenario is where we have positive margins from the seminal vesicle. That's where you can see the vas difference going down there. You can see the clips. We're not going so much into the bladder in this case. It's broadly just about covering where the prostate would be. It's not that complicated, honestly. So treatment planning technique is normally IMRT or VMAT. I myself have used quite a lot of field-in-field 3D CRT earlier on in my career, and it works just as well. We can use 6 MV photons in most cases. If the patient thickness is very high, then we can use 15 MV as well. And we normally would use 5 to 7 fields for a static IMRT plan, or several arcs in the case of a VMAT plan. These are some of the IMRT constraints. So we are basically treating two targets. The high dose target is the prostate, and the lower dose target is the lymph nodes in case of high risk disease. As I said, the rectum and the bladder, the femoral heads, the penile bulb, and the bowel are the OARs. The rectal constraints, the bladder constraints are mostly derived from the Quantec collection. So this is for conventional fractionation, but modest hyperfractionation, where we use something between 2.5 to 3 gray per fraction, is very commonly used these days, and I do that routinely in my practice. So the constraints are slightly different, but it's just about converting those doses to the equivalent dose at 2 gray per fraction, or the EQD2, and we can use these constraints for hypofractionated radiotherapy. As I said, we use image guidance, some form of image guidance, 2D or 3D. Ideally, a 3D cone beam CT would be great, but if you have an EPID, that will work as well. So at least for 3 to 5 fractions, get your average error, and then you can do it once a week. Patients during radiotherapy will normally complain of some degree of frequency of micturition, maybe some dysuria towards the end. They might have some irritation in the bowel, tenesmus, mucoid discharge, usually no diarrhea. Skin reactions, very unlikely, because this is a very deep-seated structure. Blood counts, probably when we're doing nodes and prostate, might be useful, but not really routinely required. Dietary advice is important, because patients shouldn't be taking any bulky food or any spicy foods. We all know about that. And prostate is obviously a slow responding tumor, so we will normally review them around 6 weeks post-treatment, and response assessment isn't really till at least 3 months. We would use a PSA and some form of imaging. In the past, we would use the MRI scan, but today we also have the PSMA PET scan. Now, I forgot to mention the doses. So I did mention we use both 2-gray perfraction and also modest hypofractionation. So standard dose would be for prostate 74 gray in 37 fractions, going up to maybe 78 gray in 39 fractions. And for lymph nodes, it's 50 in 25. That's for the conventional. When we're doing modest hypofractionation, a prostate would get 70 gray in 28 fractions or 60 gray in 20 fractions. The 1620 is the CHIP protocol, which I use and which I think is quite commonplace nowadays. And when we do treat the lymph nodes in this protocol, we give them a dose of 44 in 20 for the CHIP protocol or 50.4 in 28. For prostate bed adjuvant radiotherapy, it's usually a standard dose of 66 gray in 33 fractions. So we don't normally use hypofractionation for post-op prostate. And as I said, here are the references. So we have the EORTC guidelines from quite some time ago, and more recently, we've got the ESTRO-ACROP guidelines. This is for primary radiation therapy of localized prostate cancer. And we have 3 sets of atlases for post-op situations, the EORTC again, the TROG guidelines from Australia, New Zealand, and also the recent RTOG contouring atlases. So that's it. Thank you. And shall we take the questions now?
Yes, sir. Thank you for such a comprehensive presentation, sir. Most of the aspects are covered. So there are 4 questions. One is that will we only follow the DMECO risk stratification or also consider NCCN stratification?
So I think that the stratification, different organizations and bodies have used different types, isn't it? So the American Urology Association has quite a basic one, which is the one that I showed. The NCCN has gone in for these very fancy, very low risk, very high risk, etc. I don't really think as radiation oncologists we will change our approach based on those finer differences. So I think the low, intermediate, high is something that I would still be happy to consider. Monish is also asking about, will we consider Roche formula for full seminal vesicle contouring? Not really. I think if we have a high risk patient, we will use the full seminal vesicle. But the high risk is based on the T stage, the PSA, and the Gleason score. And what should be the CTV margin in case of suspicious ECE? So as I said, should be 3 to 5 millimeters around the prostate, but not around the seminal vesicle.
Okay, thank you, sir. And somebody has said the kindly record. It's already being YouTube live, so you can anytime go and listen to this presentation. And so another question, sir, now the extreme hypofractionation is coming in prostate. So planning point of view, particularly for residents, like for simulation point of view and dose, anything if you can comment on that.
So I think that's a complicated one because I mean, I don't personally do extreme hypofractionation. I think there are many centers which are using implanted fiducials to guide image guidance. So they're quite often they're using gold seeds, and they're also using the Calypso transponder system. So that would be one add-on, if you like, for image guidance in those situations. But as far as other things go, I think, you know, the target probably will still be what we discussed.
Yes. Okay, so I think if you have any other questions to the residents, if you have any other questions, kindly post. So if there are no more questions, we can go ahead to the next talk. So our next talk is on conformal radiotherapy planning aspects of GU malignancies, focusing on bladder cancer. And the speaker for this talk is Dr. Sanjay Roy, Head of the Department of Radiation Oncology, Ruby Cancer Center, Kolkata. Welcome, sir. Sir, over to you for your presentation.
Thank you, Monideepa. Good evening.
Good evening, sir.
Can you see the slide?
Yeah, slides are visible.
And thank you, Dr. Abhishek and Dr. Goswami for lovely presentation. And is it a full slide mode showing
No, it's not.
now?
Yeah, now it is.
Okay. I was given a talk, given a chance to talk about conformal radiotherapy planning aspects in urinary bladder. So, as prostate or bladder is adjacent organ, and the planning purpose, it's more or less very much similar. And let me come to the anatomical distribution first. In case of urinary bladder, you can see that it's a trapezoid-shaped hollow muscular organ with the apex, superior surface, two infralateral surface, and base and a neck. And here the apex ends in as a fibrous cord to the umbilicus. Superior surface is covered by parietal peritoneum, and base of bladder in case of male separated from rectum by prostate, seminal vesicles, and ureters, and in case of female by uterus and vagina. Inferior and lateral surface in close relation with pelvic bone, levator ani, and obturator internal muscle. So basically, it sits upon the pelvic floor. Bladder is distinctly separated from the pubic bone by retropubic space and other fatty tissues. And neck, the most inferior part of bladder, inferior portion adjacent to prostate in men and urethra in females. So here we can see the trapezoid organ. This is the bladder trigone, and this two are urinary orifice. And if we cut through and through, we can see this is the transitional epithelium, and below which it's lamina propria. And this is submucosal layer, and after that the important muscle layer, detrusor muscle, and which is separated from external surface with tunica adventitia. Regional anatomy is important for planning purpose. As well, we can see the lymphatic drainage chain of urinary bladder, mainly the pelvic nodes, two pelvic nodes, obturator, hypogastric, and external iliac preseptal nodes are the primary draining area. Here we can see as the distribution of drainage primarily in the two pelvic lymph nodal chain, obturator, hypogastric, and external iliac and preseptal nodes. Though the common iliac is not a metastatic zone, it's a secondary draining lymph nodal area, but it drains very less in that area. So next, I thought to share some investigation from our earlier ages and to the recent age. Here we see intravenous urogram where the filling defect is seen in left side of bladder. There is another intravenous pyelogram in excretory phase. We can see the filling defect in excretory phase. Here is the hydroureter as well as the rough contouring of outer portion of bladder. Here is anterior-posterior X-ray during the IVU, showing a polypoid growth. And then we come to the ultrasonogram. This is a large hypoechoic mass seen in the bladder wall. And the next generation imaging, here is the CT scan. We are often see this. There is a large big mass, and the patient came with a history of hematuria, and then cystoscopy guided biopsy was proceeded. And this is the MRI picture of bladder tumor. Now here we can see the very distinct tumor in the bladder wall. It's a T2 tumor, and the detrusor muscle, no clear disruption of signal intensity in muscle layer below the tumor. So it's invaded only the detrusor muscle. So it's a T2 tumor evident through MRI. Here in MRI image, we can see that the bladder wall is infiltrated by tumor. This is the original bladder wall and infiltrated by tumor and comes out through the bladder to external space. And is there any role of PET CT? Usually we see that PET CT, bladder, ureter, and urethra is not very much visible in bladder malignancy in FDG PET scan. But in case delayed FDG PET, we can see few images over here prominently. But issue is that here we can see two patients with a plain CT scan and CT image, and this is the FDG PET image in delayed phase. Here we can see the uptake post URBT, both the patients. Here we can see the uptake in this left anterior wall, and here a couple of uptake in right wall and superior wall. But when it was again second surgery, second cystoscopic biopsy was done, it was found to be inflammatory changes, and whereas it was found to be a pathological state. Though the SUV of both the CT image, PET CT uptake was same. So cystoscopy has been the gold standard for diagnosis. We after imaging, we suggest for cystoscopy. It's for diagnostic purpose and as well therapeutic purpose. Because through cystoscopy, we can do the TURBT and gold standard for follow-up and any adjuvant intravesical therapy, and its response also can be assessed through cystoscopy. Here is a lovely fungating growth in the bladder lumen, cystoscopic view. And this is one of the picture depicts very well the T staging. Here we can see the detrusor muscle involvement with the T2B. Here it passing through the adventitia, T3B, and involving the prostate and adjacent organ with the T4 stage. So in a brief classification, we know the superficial bladder tumor and invasive bladder tumors and metastatic bladder tumor as on presentation. And here is a brief treatment guideline as per NCCN. In early stage of cancer, especially in non-muscle invasive cancer, the role of cystoscopy, TURBT, BCG therapy, and in few high-risk cases, cystectomy. But there we find hardly definitive role for radiotherapy in non-muscle invasive bladder cancer. But stage 2 onwards, we see that there is definitely a role for chemoradiation as organ preservation method. One of the important option is definitely chemotherapy followed by cystectomy, though we know still who wants to preserve their bladder may go for concurrent chemoradiation with a definite good result, and medically unfit or unsuitable patient for surgery, they also opt for chemoradiotherapy. So as the 2D treatment already have been discussed, so today we'll possibly discuss regarding the 3D conformal radiotherapy for bladder cancer, and where after post-URBT, these are the bladder preservation for with chemo-RT in muscle invasive bladder cancer. This if the tumor is unifocal or T2 or T3, the result comes out to be the most good. And the post-URBT, the two types of radiotherapy usually we prescribe. This is one is complete chemoradiotherapy. We give concurrent chemotherapy along with 60 to 64 day of radiation, followed by surveillance, cystoscopic surveillance. If disease recurs, we go for salvage cystectomy. In case of postoperative radiotherapy, these are the indications: if pelvic node involvement or PT3 T4 disease. In case of PT3 T4 disease, if the margin is negative, we only treat the drainage lymph nodes area. So coming to the treatment planning, patient to start with patient positioning and immobilization, which is the most important part. The patient position reproducibility is of paramount important. Usually patient taken up in a supine position, knee and ankle immobilization as per protocol given for reproduction, and immobilization device like padlock we usually use. The rectum protocol is more or less same for all institutes. And bladder filling protocol, we can treat in empty bladder phase-wise. For phase 1 in 3D CRT treatment, we can treat in empty bladder protocol, and phase 2 we can treat with partial filled bladder protocol. But for IMRT treatment, usually commonly in institution, we follow the partial bladder fill protocol or full bladder fill protocol, as taking the after voiding, taking the 500 ml water, and within 30 or 45 minutes we take the scan. CT simulation, 3 mm or less slice thickness is taken, especially for early stage cancer post URBT, and IV contrast is used for proper target delineation, and simulation is done from upper lumbar spine to below the 5-6 centimeter below the obturator foramen. Image registration, fusion application with previously performed MRI and PET are recommended, and along with your surgeon's purview also taken very importantly to delineate the primary GTB area. So we need to consider that the GTB, the primary tumor volume post URBT phase, the macroscopic tumor visible on radiological imaging, if it's anything there, or cystoscopic findings provided by urologist, and fusion with the MRI or previous scan is taken for the primary GTB delineation. And CT includes GTB with whole bladder in patients with tumor at bladder base, proximal urethra, and bladder base tumor, proximal urethra, prostate, and prostate urethra male should be included in the CTB. Nodal CTB already Dr. Goswami has elaborated, and the control guideline and detailing of nodal CTB. external iliac lymph nodes, internal iliac lymph nodes along its branches, and presacral lymph nodes are of primary importance. And usually for primary PTB, 1 to 1.5 centimeter isotropic margin is taken if there is adequate image guidance in treatment center. And in case of nodal PTB, 0.7 centimeter to 1 centimeter margin is being taken. Here is some slide I would like to share with you. Here the MRI images of post-contrast T1 image. Here we can see the tumor extension beyond the wall of bladder and loss of flat pen concerning the extension of the tumor beyond the muscularis and serosa. So whenever we'll take fuse with the CT scan, planning CT scan, we'll go through the fusion image with the MRI and we'll take the primary GTV in corroborative with the MRI scan. So here we can see the CT urogram. Here the tumor is exophytic tumor is presented like that through the bladder wall, and that's why the pre simulation imaging and its co-registration are important for GTV, primary GTV delineation. Here we take the GTV with the fusion of the CTV urogram images. And these are, here we see the GTV is primary bladder tumor is infiltrated into the part of anterior wall of vagina. So the vagina and parametrial tissue. So these are taken into the red color line into primary GTV. And this is another CTV primary. What is that? The whole bladder here and along with seminal vesicles, prostate are taken. This is the CTV2 and primary CTV2. These are taken as another target volume. Nodal GTV, as we mentioned earlier, iliac nodes, presacral nodes, and obturator nodes all are considered as primary important. So here we see the contouring of L5S1 presacral nodes starting from L5S1 up to S3. Here all the 1 to 1.5 centimeter of tissue anterior to the sacrum between the vessels are contoured and the sacral hollow is taken not to miss any lymphovascular space. And in iliac nodes, generated by expanding the iliac vessels contours by 7 mm, as we know, as per guideline, contouring the common iliac and external iliac and internal iliac vessels starting superiorly at L5S1 and external iliac vessel extended inferiorly to the top of femoral heads, as already we have got it in the previous presentation. Internal iliac vessels extended inferiorly until they are no longer visible on CT scan or exit through the true pelvis via the greater sciatic notch. Here the delineation. Here we see the external iliac group of nodes and vessels. Here internal iliac. Now it's coming down the femoral head here, and this is the external iliac vessels. And here starts the obturator group of nodes. Obturator nodes anatomical boundary encompasses 1 centimeter of tissue medial to the obturator internus muscle extending from the anterior border of the ilium to the posterior border of the ilium. So contour starts from anterior border of ilium to posterior border ilium, obturator internus muscle medial to the obturator internus muscle. So these are the primary drainage lymph nodal area of bladder cancer. For post-op adjuvant RT, patients are increased risks with negative margins should be treated with pelvic nodes, as I already told, whereas patient with positive margins should be treated to the pelvic nodes and cystectomy bed. Here you can see that post cystectomy bed contouring as per GU 001 guideline above and below the pelvic symphysis. The cystectomy bed contour will stop anteriorly at the plane defined by extending line superiorly. This is the plane 1, and inferiorly from the anterior border. This is the plane 2. And posteriorly above the rectum, the contour will stop posteriorly at the plane defined by extending a line superiorly from the anterior border of the rectum. So we are sparing the rectum here, and we can see in a transverse cut that all post-operative bed and is included in the target area, and rectum and bowels area are well spared over here. So we have mainly 3 volumes we need to treat. One is primary tumor volume and with its margin. Another is the whole bladder with prostate, seminal vesicle, vas deferens, and third is the nodal tumor, nodal draining area. If the GTV is not well defined through the imaging pre-registered or lack of mapping, we can see then the entire bladder is taking as the boost volume. So again, once again, the repetition of slides that this is the GTV with one volume, this is the boost volume, and this is the another CTV volume. We'll discuss about the dose regarding the all 3 volumes, and this is the nodal VTV area. You can see there's nodal drainage area coming down from presacral and iliac vessels, and coming down, it's the obturator group of nodal area, and obturator group of nodal area, and this is the primary PDB. So conformal treatment planning. To confirm the treatment, we need to give our physicist or dosimetrist the mentioned volume, mentioned PTV to give the targeted prescribed dose. And for this reason, they usually plan through forward planning, and which is called 3DCRT, and another is inverse planning. So in case of forward planning, they use usually for fatty patients 10 to 15 MB photon they sometimes use, otherwise 6 MB photon is adequate. Optimize a 3D conformal plan, and usually 3-field or 4-field are used. And here we can see that this is the 3-field technique using the wedge and MNC and sparing the rectum with keeping these 2 anterior posterior oblique field with a 110 degree to spare the rectum maximum. Here is the 4-field 3DCRT planning, where the rectal dose is reduced by negotiating the weightage and energy and angle of the beam. And next, in IMRT planning is the inverse planning procedure. Potentially reduce the dose to normal tissues maximally, and it allows the delivery of synchronous boost needed for partial bladder irrigation and permits also dose escalation. But IMRT requires excellent immobilization, as we know, because without IGRT or without imaging support, localize or to locate and minimize the PTV at time of treatment, it becomes very difficult. So without IGRT or with the minimum image support, usually the 1.5 to 2 centimeter PTV margin is usually given. But with the daily imaging basis, we can keep it down up to 1 to 1.2 millimeter. That we'll discuss later. Here, you can see IMRT planning of the bladder area, and the rectum is spared fantastically. Here is upper slide solar 3D CRT planning, and below BEF or IMRT planning. We can see the modulation of the isodose posteriorly, sparing the rectum with radius. So, in case of dose delivery and dose prescription, we can use the normal fractionation of 40 to 45 gray to the whole pelvis, primary volume PTV as well as nodal PTV. And then we can boost the bladder up to 64 gray at conventional fractionation. There is another alternative fractionation schedule. Usually we used to treat, that's a 55 gray to N20 fraction, but usually nodal chain is not treated with the with this type of 2.75 per fraction hypofractionation schedule. For clinical node positive disease, we need to consider boosting of involved node up to 64 gray if it can be achieved safely with image guidance. Post-op adjuvant radiation dose usually 45 to 50 gray in conventional fractionation. And dose constant, already Dr. Goswami has discussed. Rectum and femoral heads are standard wear as well as small bowels. So after the planning, we need to achieve few things before validation of the plan. We need to see the dose distribution in the PTV, if any, it's within normal limit of 95% to 103%, and we can through the DVH we also need to validate the plan. Here we can see this plan was done in full bladder, and this bladder was the empty bladder, and this bladder was done in a full bladder. So the difference between the bowel dose in both the plans are significant, and we can see the therapeutic ratio is much more better in this plan. So problem is that the delivery of the IMRT plan is complicated, and its main problem reason is the motion of the bladder. So IGRT daily KV imaging or MV imaging is needed to accurately deliver the prescribed dose. So here we have a solution for this motion management. This plan of the day adaptive radiotherapy technique is a very interesting option. We can go through this way, that it entails the generation of 5 or 6 isotropic PTVs for each patient at the time of planning, and thus generation of 6 separate IMRT plans for each patient. Dr. Vedamurthy conducted this study, and he showed that on helical chemotherapy treatment and daily MVCT image guidance scans were used to correct for patient positioning errors and choose the most appropriate PTV, depending on the shape, size, position of the bladder on that day. So here we can see the 6 PTV or 5 PTV are drawn, and for every PTV the our new planning is done before the starting of treatment. So the study has the basic protocol. The 5 non-pointer scan were taken with the 3 mm slice thickness and with the standard bladder protocol. The whole bladder was delineated as the CTV and 6 PTVs with the 5 mm of margin up to 30 mm. In CTV, boost volume was given a uniform 10 mm margin to generate the PTV boost volume. So for each treatment fraction, a pre and post-treatment MBCT scan was taken. Pre-treatment MBCT was co-registered with the planning KVCT scan using a automatic fusion for bony anatomy. So it was selected the PTV compass encompassed the bladder with at least a clear visible 2 to 3 mm margin to account for potential intrafraction motion. So here we can see the co-registration of planning and KVCT and MBCT, and bone matching, automatic bone matching showed that mismatch of the bladder in axial and coronal planes. So selection of the plan of the day by fitting the bladder into the most appropriate PTV margin, and it gives the best outcome. Here we can see that in 99% of the fraction were treated within 5 to 15 millimeter PTV, and 90% of fraction were treated with the 5 and 10 millimeter plans. So we can reduce our PTV margin on daily image guidance or daily imaging basis. So 2 centimeter, 1.5 to 2 centimeter margin we can reduce in 1 to 1.2 centimeter margin if we can treat through plan of the day. But there is a problem with the logistics and other time and other things. And they also did this anisotropic margin for VTB, and the margins needed to encompass the bladder wall in each direction, because the bladder wall doesn't move in same way in all the wall. So 85 to 95% of the time during the course of the ABRT were taken, and using this data multiple anisotropic PTVs was generated and used for adaptation. And lowest most, the 85th percentile PTV was taken for the anisotropic margin as anisotropic margin, and it showed that 85% of time or 85% of fractionation were covering the anisotropic margin PTV. So IGRT-based adaptive radiation involving the daily choice of several PTVs is feasible and effective alternative to generate large PTV margin. So it allows greater sparing of surrounding normal tissue and dose escalation in bladder cancer. The famous Dr. Parodi did a few studies over this plan of the day treatment, and he found a significant result. Here we can see this study done here with 64 grade 32 fraction. Those were given, and 3 POD plan of the day treatment given. Here we can see the 29% reduction in normal tissue dosing. And in this study, in this the recent study, here ART reduced the irradiated volume with imported target coverage. So if plan of the day treatment is considered for adaptation, then we can reduce the PTV margin considerably. And this is the latest one paper I found out, that where it's seen that online adaptive radiotherapy of urinary bladder cancer with full re-optimization of the anatomy of the day. Where here what is they have done, 16 patients they taken, and most of the fraction they did through the normal PTV margin non-adaptive fractionation schedule. Few 2 or 4 fraction of they treated with the adaptive margin because they got this margin from the non-adaptive radiation fraction, and they took the PTV, extracted the margin on the day of OART treatment fraction day, and the target volume, coverage, and time were compared between the 2 arms, online ART arms and non-ART arms. And on conclusion, they showed that large reduction in treatment volume and those two organ at risk compared to non-ART arms, while uh, ensuring the target coverage. So this is a potential reduction of small bowel toxicity we can see. So this study has demonstrated the feasibility and time efficiency of CBCT guided online adaptive radiation for bladder cancer with full reoptimization of the anatomy of the day. So, and this online reoptimization was done through artificial intelligence. So on ART required additional treatment time compared to non-ART resulted in reduction in treatment volumes and dose volume parameters for organ at risk, indicating the potential reduction in the future toxicities. So from 2D to 3D, 3D to conformal, and conformal to IMRT, IGRT, adaptive radiation, and on present days, taking help of AI machine learning for enhancing maximum therapeutic ratio. Science is making our human life better for in leaps and bounds. So all about. Thank you.
Thank you, sir, for such a nice presentation. We are having few questions. And, which method is preferred? Is it continuous or split course for muscle invasive bladder?
So, hello.
Yes.
Yeah, I could not hear you. Sorry.
Yeah. So there's a question from Abhay. Is which method is preferred, continuous or split course for muscle invasive bladder cancer? I think continuous.
Continuous.
Yeah.
Continuous. We usually treat that continuous treatment of 30 to 32 fractions and followed by normal surveillance follow.
Okay, another question from Abhay only. What are the indications of post-operative RT in bladder cancer?
Yes, for advanced tumor, T3, T4 tumor, usually we consider for post-op radiation along with positive surgical margins. We need to give radiation to the surgical bed.
Yes. And another question, another two questions from Dr. Manishi is that during boost with 3D CRT, will we follow full bladder or empty bladder protocol?
Follow during 3D CRT boost, as per there is no fixed guideline or protocol for anything. As per institution wise, we choose our treatment, but partial failing of bladder may give rise to benefit if we treat traditional 3D conformal therapy, because visualization of tumor bed and its contouring and giving the margin will be better, and the differential dose to the whole bladder will be less rather than the boosting the boost volume, that GTV primary volume.
Okay, sir. And during IMRT, should we consider anisotropic margin in partial bladder protocol? This was another question.
During IMRT, should
we consider giving anisotropic margin in partial bladder protocol if you are treating partial bladder? So any anisotropic margin concept is there on?
Yes, anisotropic margin, actually putting in practice the anisotropic margin is very difficult. We need to be very thoughtful and very wise regarding the onboard imaging, which is getting done. And on basis of that, we can take the all 6 to 8 angles of bladder movement on anisotropic axis. We need to consider these things. So I don't know it's possible, but with logistics and resources, we need to consider it in a clinical trial, I think.
Okay, and there's a last question done by Joita, that in bladder preservation process, what dose is given to whole bladder PTV and up to what tumor PTV boost dose is given? So I think that has been answered by Sir.
Yeah, if it's ultimately the dose is around 62, 64, 65 gray in conventional fraction, but what will boost, that depends on the tumor location, distribution of tumor, any other presence of any other focus or carcinoma in situ, anything else. And if you cannot cannot draw the GTV primary on the basis of the previous investigation or cystoscopy findings, then I think it will be better to give the whole bladder radiation up to 62 gray.
Okay, so I think there is no more question. Thank you, sir, for answering the questions. So I think today we are at the end of our today's session, and we had a very excellent talk by two eminent speakers. And this session will end here. The next session is on GI malignancies, and the date and what program we have, we'll post it in the group pretty soon. Thank you to all our speakers, our panelists, and all our residents for joining. Thank you all again. So I'm now ending the session. Thank you, sir.